Yes.
So before lunch, we were you were giving. I was asking questions about the position as it was in September 2016. We were looking at those meeting minutes. Has there been any development on getting the DDA up and running since then?
No, what happened after then is that, rather surprisingly, the Department of Health came out with a call for proposals for research in variant CJD to address public health issues around risk assessment and indeed around surgical instrument decontamination. So we thought it was worth having a further go. Graham Jackson put in an application again to do the sort of prevalence study that we'd talked about previously, updated in the light of subsequent events, but essentially a similar study, but that was rejected on triage. It didn't even go out to international peer review, it was just rejected.
And sorry, I didn't catch what you said. Rather surprisingly, DOH came up with something proposals. It sounded like call.
A call for proposals. They put out calls and say, there's a pot of money. We're interested in receiving applications to answer these particular questions.
No, I couldn't hear you say call for proposals.
Sorry.
I understand. So, why what do you understand to be the reason why Department of Health and other organisations, MRC, have been unwilling to take the steps that you've outlined to get the DDA, or indeed any other blood test around, although I understand there weren't any as far advanced as yours, to a stage where it could be used as a screening test?
I'm not sure I know the answer to that question. I think you'd have to ask the Department of Health and the MRC. I've been perplexed as to why we weren't able to take this forward, which was all publicly funded research that we were asked to do.
Do you think do you think that the decision making has been influenced by the fact that there's no treatment for VCJD?
I guess it's possible. I don't know whether that was a strong factor or not.
Is that something that was ever raised with you or discussed with you?
Not really. There were extensive discussions about notification of people testing positive. I know that was a big area of concern for the Department of Health and the Blood Service.
Now, we know from your witness statement and from other evidence and other information that there hasn't been a VCJD infection since 2015. Is that right?
Mm-hmm. As far as I'm aware, yeah.
Given that we're now in 2022, what do you say would be the benefit of having a screening test for VCJD for blood donations?
Well, I think these, will inevitably come down to health economic considerations from the Department of Health, or whether they feel there's a benefit from introducing a screening test at this stage, given that thankfully we haven't seen any cases for some years. But there are still concerns. The Health Protection Agency's study of appendices, found 1 in 2,000 positive. So that doesn't, as yet, thankfully, have translated into more clinical cases, but it's unexplained. And it implies there is quite a pool of infection in the community which isn't working its way through to clinical disease. And I think a blood screening study might help clarify what was going on there.
So it might help interpret and understand what the 1 in 2,000 result actually means.
What that actually means, yeah. Obviously, from a public health point of view, what's in the blood matters rather more than what's in the appendix. Also, from my point of view as a clinician, it would be very helpful to have, if we were able to validate the test to detect healthy but infected individuals, that could be used in counselling of individuals who wanted to be tested if they had a significant exposure. And going forward, to be able to offer them treatment. Ideally, the best time would be offered treatment was before they'd actually developed signs of the disease. And the monoclonal antibody drug we've developed that we recently published in Lancet Neurology was actually developed with that intention, that it could be used for so-called secondary prophylaxis, that is to say people who were accidentally infected, for example, from blood transfusion or blood products. If they then tested positive, even before they developed any signs of the disease, they could be treated with the monoclonal antibody, which would hopefully eradicate the infection and prevent them ever getting the disease. So that was and remains an important aim of ours.
And you've made reference to this at several points in your evidence, and I keep saying I'm going to come back to it. So you've told us that you have been approached by members of the patient population who were notified that they had received implicated plasma products, i.e. plasma products where somebody who'd then gone on to be diagnosed with VCJD had contributed to the pool. And they have approached you for diagnosis, is that right?
I think from memory, mainly for counselling. I mean, we haven't offered the DDA test as a predictive test because we don't have sufficient information to know what a negative means. I think a positive we could interpret, but a negative wouldn't give much, if any, reassurance. We simply don't have the data to back that up. So we've not used it in that purpose. So our role has really been in counselling individuals who want to talk to us about their risk. But I think if our therapeutic antibody gets to a further stage, we're currently trying to get support to do a formal phase 2 study. If that is done and it's successful and the drug is ultimately licensed, then that alters the calculations considerably in that you'd want to be perhaps more proactive about offering testing to people who might have a reasonable chance of going on to develop this disease, with the aim of preventing them ever getting the disease.
And before you would be able to offer them the DDA test, you would need to do the work that you've outlined to us this morning, so that the large prevalence studies in the two different populations.
Yes, we don't know at the moment whether the test would detect healthy carriers of the infection.
And just sticking with that point about what you could offer the at-risk population that have had implicated plasma products. At the moment, you've said just counselling and that kind of support. What about something like a biopsy of the tonsil? Is that something that could be offered to that group of patients currently?
It's conceivable. I don't think we would offer that. It's a surgical procedure. It's a relatively straightforward one, but all surgical procedures carry risk. I don't think we'd be liable to go down that route unless the risk was substantial. And at the moment, we don't have a treatment to offer. Certainly the group of people we were talking about earlier who'd had been exposed by direct transfusion from an infected donor, where the risk is, we think, considerably higher, and we had the treatment in our hands that we were confident could eradicate the infection, then I think tonsil biopsy would certainly be something we would discuss. And if they had a positive biopsy, that may then lead to us offering them treatment.
And I just wanted to pick up one more point with you from your witness statement. We were discussing earlier, before we got on to that last point, the benefits of of introducing a screening test for VCJD at this point. And one of the issues that you raise in your witness statement is that there are cases of sporadic CJD which are continuing to rise. And what you say is you can't exclude whether a fraction of them may represent BSE-related cases manifesting as SCJD. And you say that may be a reason for introducing a blood screening test at this stage. Could you just explain to us why that is?
Yeah, it's a factor. As I mentioned, there's the unexplained 1 in 2,000 from the HPA study of appendices, but also Every year, pretty much, we're seeing more and more cases of apparently sporadic CJD diagnosed in the UK, and the general interpretation of that is that we're getting better at diagnosing it, and that probably is the majority of the explanation. But it's possible that a proportion of that is cryptic BSE infection. And one of the reasons I say that is because we did experiments we published in the literature, I think more than a decade ago now, in animal models. We have genetically engineered mice which express human prion protein and can use these to study the behavior of different human prion strains. And what we found is when we infected these mice with BSE prions or variant CJD prions, is that the patterns of pathology produced in these animals could look just like variant CJD, but also they could induce patterns of disease and prion strains that looked like sporadic CJD. There's a genetic polymorphism in the population as well that affects which strains propagate in different individuals. So we suggested at the time we published those papers that it may mean that some patients infected with BSE develop a disease that clinically looks like sporadic CJD rather than variant CJD. We have got no direct evidence that has actually happened, but the animal models suggest that that can happen. And given that we are seeing this rise in apparent prevalence of sporadic CJD, I think we have to consider that whether some of it could be cryptic BSE. And we did report a patient in the literature, I'm not sure whether you have that paper, where both clinically and in terms of their brain imaging appearances, the diagnosis was of sporadic CJD according to the epidemiological criteria. But in fact, the patient had variant CJD when autopsy was performed. So there was the clear example of it actually had happened. That case would have been classified as sporadic CJD had an autopsy not been performed.
And for that group of patients, what do you know about the infectivity of their blood, or prionemia in their blood?
In the sporadic CJD patients.
In the crypto-BSE sporadic CJD patient?
Well, we don't know. We didn't know from that particular patient. I'd need to look at the paper again. I think the DDA was done in that patient and it was negative, but I would have to check that.
And then lastly from me, given the difficulties you've experienced both in terms of the DDA and in terms of the work you did on the decontamination of surgical instruments, do you consider that more should be done to improve the connection between research and specialist knowledge and government decision making?
I think government policy should always be underpinned by the best available science.
So those are the questions that I had for Professor Collinge. I've had a few questions from core participants, but what I was going to suggest is we have a short break now to see if there are any more, and then I ask them all at one go.
Yes, very, very well. Well, let's do that. How long do you think you might need?
I don't think more than 10 minutes.
Well, let's give you 15, just to be clear, and come back again, therefore, at, shall I say, 20 to 3. The purpose for this is to give core participants a chance to put questions to Council for her to ask you. And to give them that opportunity, they may be in the room, they may be listening remotely. We take a break before finally concluding the evidence. So the last session will come at 20 to 3. How long it'll be, I don't know, because I just don't know how many questions there might be. I suspect there may not be very many, but there might be. We'll find out. We'll find out at 20 to 3.